Good morning, everybody. And as always, thank you for being with us today as we're giving you a minute or so for everybody to join in today's medical grand rounds. We have a really great presenter today. We're looking forward to hearing Dr. Carnes speak. I'm next going to turn over to Dr. Dunn, our Associate Chair of Diversity Medicine, to talk about our Department Diversity Awards.
Good morning, everyone. Happy Women in Medicine Month. I am really honored to announce the recipients of the 2021 Chair Diversity Awards. We received a number of wonderful proposals, which made our job even more difficult, but I can say I am very proud that there is so much of this amazing work being done across the department focused on diversity, equity, and inclusion. First, I want to thank Dr. Harrington and Kathy Garzio for making these awards possible. And then I also want to thank the esteemed members of the review committee, which included Drs. Chertow, Dr. Stefanik, Dr. Felsher, Dr. Kim, and Dr. De Jesus Perez. And additionally, for our holistic review, I want to thank Dr. De Jesus Perez and Dr. Harmon for helping with that process. Thank you to everyone for your time and effort for making these awards possible. And without further ado, we have 4 dynamite proposals that will help make strides toward health equity. So Dr. Shoa Clark, addressing racial disparities in the clinical assessment of polygenic risk for coronary artery disease. Dr. Robert Huang, the Neighbors Study, understanding how community-level immigrant diversity mediates the neighborhood physical and social environment to modify health behaviors. Dr. Maria Juarez Reyes, reducing healthcare disparities among Spanish-speaking Latinx patients, a community-based behavioral health intervention. And last but not least, Dr. Andre Kumar, investigating inequities in training evaluations for women and underrepresented minority physicians. So please join me in congratulating these amazing investigators. We really look forward to seeing how this work comes to fruition. Thanks so much, Dr. Ustalka.
Thanks, Dr. Dunn. And also, Dr. Harrington, I'll turn over to you for a few comments.
Yeah, so first off, I want to thank Kathy for helping me think through the issues around these investigator awards. It's become a really important part of what the department does over the last few years. My congratulations and thanks to you, Dr. Dunn, for leading this effort so spectacularly. And just congratulations to all of you who submitted applications, because we could have awarded double this and easily have gotten the same high quality. So keep working on these important issues related to diversity and health equity. It is an important part of the research we're doing here in the department, and I very much look forward to seeing our award winners present at medical grand rounds over the coming year. So thank you, Dr. Dunn. Thank you, Dr. Harmon, the rest of the group who led the application review. Back to you, Errol.
Thanks again, Dr. Harrington. Again, Dr. Dunn, thank you for that great overview, and congratulations to our winners of these awards. I'm next going to turn over to Dr. Harmon, who is our Associate Chair of Women in Medicine. She is, as I mentioned last week, been instrumental in really setting up the presenters this week, and she's going to add some words and introduce Dr. Carnes today as well. Thanks, Dr. Harmon, for everything this month and everything you've been doing. I'll turn it over to you.
Thanks, Dr. Ustalka. Get ready for a whirlwind of announcements. So a lot of things going on this month to celebrate women in medicine. The first that I wanted to highlight, and we'll put the registration link into the chat, is Inclusion Round, September 23rd, and entitled Intersectionality and the Experience of Black Women in Medicine. Dr. Tamara Dunn will be moderating, our Associate Chair for Diversity. It will include Dr. Diana Sejas, who is Professor of Neurology at North Carolina and specializes, all of her patients have disabilities. Dr. Vanessa Grubbs, who's a California Healthcare Foundation contributing writer and the primary care physician and a nephrologist, and Dr. Stella Saffo, who is a New York Academy of Medicine fellow and founder of Just Equity for Health. September 23rd, that's actually at noontime virtually, 12 to 1 p.m. Next slide. Next, I wanted to just point out that we're going to have Women in Medicine features all month long in our Department of Medicine communications. So you would have seen that coming through in our newsletter. We've had a takeover, and a number of different women in the department are going to be speaking about their experiences. You can see actually all the women we've highlighted every day of this month so far in our social media, and there's a full link with regards to their profiles Thanks to our communications team, Lindsay Baker, and Dr. Ozdalga as well for basically getting all this prepared, and every day you'll see something new. Next slide. I wanted to highlight an event that is actually school-wide, hosted by the Office of Faculty Development and Diversity, the Gender Divide and Negotiation. And this is a workshop that's going to be run by Jessica Notini, who is an adjunct professor at Stanford Law School and is a principal of a mediation, facilitation, and training services program. So that is a registration link you can also find on our Women in Medicine website at our department website. Next slide. And just another reminder, we're going to have our annual photo. The background that you see behind me, part of that is from last year's virtual photo. We're going to do a hybrid version this year with an in-person photo for folks on site from 12 p.m. to 12:30 p.m. And then virtually 4 p.m. to 4:30 p.m. Wear red and white coats, just like we did 2 years ago when we were in person. And that will be still at the same site by the Clark Center. As you can see for the in-person and virtual, there'll be a link that'll be sent out. And finally, last slide, upcoming grand rounds. I wanted to highlight both the Women in Medicine grand rounds as well as celebrating Hispanic Heritage Month, which overlaps between September to October. So I will be introducing our speaker, Dr. Molly Carnes, shortly. Next week, we'll have Dr. Madeline Deutsch from UCSF. She'll be speaking on transgender adult health and clinical medicine, the state of the science. September 29th will be Dr. Narjus Duma. And then October 6th, we'll have Dr. Bonnie Maldonado, our own Dean for Diversity and Inclusion here at the School of Medicine. And now is my great pleasure to introduce Dr. Molly Carnes, who is our speaker for this morning. Dr. Carnes is the Virginia Valian Professor of Medicine, Psychiatry, and Industrial Systems Engineering at the University of Madison, Wisconsin, where she directs the Center for Women's Health Research in the School of Medicine and Public Health, and co-directs the Women in Science and Engineering Leadership Institute at the College of Engineering, which is known as WISELI, very apt name. Dr. Carnes received her undergraduate degree from the University of Michigan and her medical degree from the State University of New York at Buffalo. She then completed her internal medicine and geriatrics training at the University of Wisconsin, where she also received a master's in epidemiology. Her research examines how stereotypes perpetuate inequities. Approaching unintentional stereotype-based cognitive processes as habits, she mobilizes behavioral change strategies to help faculty in medicine, science, and engineering break the bias habit. And with support from the National Science Foundation and the NIH, Dr. Carnes has developed and tested interventions that changed faculty behavior, improved department climate, and increase the hiring of women and the retention of faculty overall. She's currently leading the Bias Reduction Internal Medicine Study, which is a 19-site cluster randomized control study of a bias habit reducing workshop. And she's published over 165 papers, served on 2 terms on NIH advisory councils, and has received numerous awards for her research, including the 2019 Bernadine Healy Award for Visionary Leadership in Women's Health. In the pandemic, she has continued her work in bias reduction training. And so I'm really looking forward to hearing about her workshops and the BRIM study. She's taken bias to even looking at the virtual environment as well, with a recent publication on how to promote gender equity in the virtual environment, very apt for the pandemic. Please join me in welcoming Dr. Carnes. Her talk is titled, "Bias is a Habit That Can Be Broken." Dr. Carnes.
Great. Thank you very much, Dr. Harmon. It sounds like there's so much interesting stuff going on here at Stanford. Congratulations to all the Diversity Award recipients. It looks like really interesting research. I want to come back for those grand rounds. Anyway, I'm delighted to be here, or to be home, but here virtually, there in Palo Alto virtually. I'd just like to start by thanking many people who've contributed to some of the research I've done over the years, and also thanking those who have funded my research, including NIH, NSF, and the University of Wisconsin. So I'm going to cover 4 points today. Making the point first that stereotypes by their mere existence, underlie both overt discrimination, but also perpetuate unwitting, unintentional bias, so-called implicit bias or unconscious bias, that we all know these cultural stereotypes, even if we consciously disavow bias against any group, but that just knowing these cultural stereotypes creates cognitive bias habits. And these habits distort the perception even of ostensibly objective information. But these cognitive bias habits can be broken like other habits, but just like breaking any habit, takes more than good intentions. It takes hard work. So let's just start with some data. If we look at data from the AAMC and the NSF Survey of Earned Doctorates, these are percentages. If you are someone who identifies as a member of an ethnic or racial group that has been historically marginalized in this country, so Black or African American, Hispanic or Latinx, Native American or Native Alaskan, a member of an indigenous population of Hawaii or other Pacific Islands associated with the US, like Guam. Okay, so if you identify with a member of this group, you are underrepresented across all stages of careers in academic science or medicine relative to the percentage in the US population. So you can see on the left, medical students, biomedical PhDs, all the way to chairs. Now, if we look at percentages of women, mostly white women, but if we look at percentages of women, there's no doubt that there has been tremendous progress in this country in opening the doors of essentially all fields of science and medicine to women since Title IX of the Civil Rights Act. The Education Amendment of the Civil Rights Act was passed in 1972, making previous quotas that kept women out of higher education illegal. And so, for example, the far left bar, in medical school, we've had essentially gender parity of our medical students for decades. Similarly with biomedical PhDs. And I think we can take some pride in the fact that in internal medicine, about 40% of our residents have been women, again, for decades. And we don't see a drop in that percentage when we go to the assistant professor level. But we do see a disproportionate loss of women as we go to subsequent career stages, particularly toward leadership. And no matter how you model that, it is a disproportionate loss. And we see that same pattern if you look at so-called well-represented minorities. So these are individuals who identify as being a member of one of the multiple subgroups that the way our country counts demographics are subsumed under Asian. So well representation relative to the percentage in the US population at the early pipeline stages in an academic career in science or medicine, but a disproportionate loss of talent as we move up the career level, particularly toward leadership. Okay, so I'm going to kind of come back to the data on these three slides several times during the presentation, because I think some of the concepts I'll be giving you and the information I'll show you will help you understand why these data exist and why they're so hard to change. Okay, so we know common stereotypes, even if we don't believe them. And to make that point, I'm just going to start with a gender context. So even though we know gender does not exist as a simple binary, but along a much more nuanced continuum, if you live in this society, you are aware of binary gender stereotypes about men and women. Even if you don't believe them, you know them, right? So if I asked you to just spontaneously generate off the top of your head common stereotypes about men, you could easily do that. And study after study after study for decades have done this, and they come up pretty much with the same stereotypes every time. So they come up with the fact that stereotypically men are viewed as strong, decisive, stubborn, ambitious, risk-taking, authoritative. And these traits and behaviors that are stereotypically associated with men are termed agentic traits and behaviors. It's assumed they require kind of individual human agency. Okay, well, what about women? You could do the same thing. If I said what are some common stereotypes about women? You could easily generate a list of stereotypes. And again, study after study has done just that. And for the last several decades, every group that generates this comes up with very similar stereotypes, that women are stereotyped as being caring, nurturing, family-oriented, emotional, nice, helpful, dependent. And these are referred to as communal traits and behaviors. So it turns out we also know common stereotypes about different racial and ethnic groups. And this was demonstrated quite clearly in a study from UCLA that involved a very diverse group of participants. So over 600 participants, only 26% identified as white, 22% were born outside the US. And the investigator said, don't tell us what you personally believe, but what kinds of stereotypes have you seen portrayed about these different racial and ethnic groups in your environment, in movies, in the media? So I'm going to list the stereotypes they came up with. These can make you uncomfortable. They can even be triggering, but this is what the investigators found. So stereotypes about white people: high status, rich, intelligent, arrogant, privileged, blonde, racist, all-American, ignorant. Stereotypes about Asian people: intelligent, bad drivers, good at math, nerdy, shy, skinny, educated, quiet, passive. Now I'm going to put up the stereotypes about Black people and Latinx people, and I will warn you, these are painful to read. But just like gender, if you live in this society, the content of these stereotypes is not going to surprise you. You are aware of these group stereotypes. So stereotypes about Black people: ghetto or unrefined, criminal, athletic, loud, gangsters, poor, unintelligent, uneducated, lazy. Stereotypes about Latinx: poor, illegal immigrant, uneducated, family-oriented, lazy, unintelligent, loud, gangster. So these stereotypes and the fact that we know them are at the root of gender and race bias, systemic racism, anti-Blackness, and unintentional implicit bias. And these stereotypes influence who in power, who they choose to admit, fund, mentor, sponsor, and reward, and they shape individuals' decisions as they decide what career they fit in, what medical subspecialty they fit in, right? Is it interventional cardiology, sort of a male stereotype subspecialty, or is it a more communal specialty like general internal medicine? And in general, Black and Latinx individuals are stereotyped in ways that are incongruent with perceived success in academic medicine. All right, so some things you need to know about stereotypes. They persist even in the face of disconfirming data, because that is the way the human mind works. If we know something, we tend to pay a little bit more attention to information that affirms what we already know, and we sort of ignore contradictory information. And we see this in clinical decision-making, right? You've heard about confirmation bias and anchoring bias, right? Where you tend to pay a little bit more attention to that clinical information that affirms that diagnosis you initially thought the patient had. So stereotypes are the same way. You know them, as we've just shown. So you may interpret the exact same behavior, for example, in a Black medical student and a white medical student differently, because that behavior in one case might align with a stereotype and the other case not. You know, what if that student is late for rounds? You might pay attention to that in the Black student and just ignore it in the white student. Also, a trivial piece of information brings the entire content of the stereotype to mind. You know, a name, skin color, what somebody's wearing, where they went to school, an accent. And once that whole stereotype pops to mind, all subsequent information is filtered through that stereotype. And that happens even if you don't believe the stereotype, just knowing the stereotype, and even if the data being filtered is objective. And we tend to apply group stereotypes at the individual level. So, for example, I'm from Wisconsin. You probably just assume I like beer, cheese, and the Green Bay Packers. Those are stereotypes of people from Wisconsin. And I can tell you there are many, many people in Wisconsin who do align with those stereotypes, but not everybody. Right? We have some people who prefer wine to beer. We have Vikings fans. And finally, as you can see, depending on the situation, these stereotypes can create stereotyped advantaged and stereotyped disadvantaged groups. So just as we have stereotypes about different groups of people, different social categories, we also have stereotypes about different occupations and different roles in those occupations. And so research looking at stereotypes about leaders show that people say traits about leaders are stereotypically that they are competitive, self-confident, aggressive, ambitious, powerful, decisive. So now reflect back to those group stereotypes from that UCLA study. Where would you get more alignment, more role congruity, as Alice Egley uses the term, between stereotypes about leaders and stereotypes about different groups, say white people or Asian people, right? Clearly, there is a much stronger fit, a much stronger role congruity between stereotypes about white people and leaders than there are Asians. Now, remember that disproportionate loss of talent among Asian faculty as they move toward leadership. Now that you know about how these group stereotypes can filter information, can filter evaluation of individual people in one of these stereotype groups, you have to ask yourself whether these stereotypes about Asian people contribute to that loss of talent among our Asian faculty as they move toward leadership. Now, returning to a gender context, remember those agentic traits and behaviors associated with men and the communal traits associated with women. Where would you get better role congruity here with leadership? Pretty clearly. In fact, this is called the think manager, think male phenomenon. Virginia Shine's lab has studied this for years. She's found this is a phenomenon that exists cross-culturally in the US and Europe and Asia. Persistently, this think manager, think male phenomenon exists. Now, remember I told you how stereotypes resist disconfirming data? This is a clear example of this, because despite the ubiquity of this think manager, think male phenomenon, there's a lot of research on leadership. And it pretty consistently shows that across all settings, leaders who enact leadership with a transformational leadership style are the most effective leaders. So transformational leaders are leaders who are able to inspire members of an organization to invest their time and energy beyond their own self-interest. These are very valuable leaders. Transformational leaders do indeed draw some behaviors from the agentic column. They may be strong, they may take some risks, hopefully they're logical. But think about your most effective leaders. Transformational leaders draw a lot from that communal category, right? They care about members of the organization, they nurture talent. Hopefully they're even nice and supportive. Nevertheless, that think manager, think male phenomenon persists. Now, staying in the gender category for a moment, because we know these binary gender stereotypes, they create what could be thought of as gender rules, these sort of normative expectations for men and women. And both men and women who violate these prescriptive gender norms will suffer social penalties. And we know this if for no other reason than we have words in the English language to describe men who are viewed as too communal. Right? These are not flattering terms, words like wimpy, sissy, weak. And we have words to describe women who are viewed as too agentic, if you will, right? And again, these are words that are not going to help you in a performance evaluation. Words like bossy, domineering, abrasive. But you can see how this can place women leaders in a difficult situation, because if they behave in ways that they think are stereotypic for leaders, it it puts them in a position of potentially violating these prescriptive gender norms and suffering the consequent social penalties. But again, the good news is that the most effective leaders, these transformational leaders, draw behaviors from both columns. They have a lot of communal behaviors, and there's some research to suggest that women may actually be more likely than men to lead with a transformational leadership style. All right, so I want to be clear that these negative performance expectations that would arise from these gendered stereotypes for women are not borne out by actual data. So just to select a few studies relevant to academic science and medicine, in one study of a large HMO, they found that patient satisfaction scores for women physicians were significantly lower than their male counterparts, even with the same objective quality metrics. And in a study that did natural language processing on essentially all doctoral dissertations in the US over about a decade, to look for novel ideas, they looked for unique co-occurrence of new scientific phrases and words. They found that the dissertations from women and non-white men had less future impact on science. That is, these people were less likely to become faculty members. Their research was less likely to result in a publication, but they had more novel ideas. And finally, in a study looking at a large grant program through the Gates Foundation, Koliv and colleague found that looking at applicants who were funded, the proposals from women had actually received worse scores than the proposals from men. But when they followed them out after the grant was over, women were significantly more likely than men to secure subsequent NIH grants and publish their work in top journals after receiving the grant. So just wanted to be clear that these stereotypes are not based on fact. Okay, so because securing competitive grants is such an important part of succeeding in academic medicine and science, it's informative to look and see whether this kind of lack of fit could negatively impact women's ability to secure grants. And research suggests that that could definitely be happening. So for example, in one study, when participants were asked to select traits for an average man or an average woman, those selected for an average man strongly overlapped with traits they selected for a successful scientist, but traits for an average woman did not. Two studies have found that creativity and innovation, two things highly valued in reviewing grant applications, creativity and innovation were more strongly associated with male than female gendered stereotype. So one has to wonder whether this kind of lack of fit might account for or contribute to the observation that the success rates for new RO1s, type 1s, are the same for male and female applicants, sort of early career applicants. But for renewals, RO1 renewals, the type 2s, where you would have applicants who are both scientists and leaders, right, where women would sort of get that double lack of fit, the success rate for female applicants has been lower than the success rate for men by 2 to 8 percentage points since NIH started putting the data on their website, 1998. Although I looked at that graph on their website in preparation for this lecture, and for the first time since 1998 in 2020, the success rate for the type 2s is the same for men and women. So go NIH. Okay, so if there is this bias that is disadvantaging women in scientific grant peer review, is there anything they might do about it? And so knowing about this lack of fit and this sort of negative performance expectation for women in science, I would say generally anything women could do to reduce activation of female gender stereotypes in their grant application would probably be a good idea. And so just sort of taking this recommendation from the research and extrapolating it to this recommendation, there is a series of elegant experiments by Atier and colleagues. And first, they showed that in this country, it is far more common for men to be referred to by last name only than women. And then they showed in several experimental studies that when a scientist was referred to by last name only versus their full name, participants thought the last name only scientist was more eminent and 14% more deserving of an NSF career award than the full named applicant. And when there was a joint application, they would recommend allocating the last name only scientist a larger share of the joint award. So I would suggest women, when you're writing your grants, refer to yourself by last name only. Also, it's probably a good idea to focus on the approach as in NIH grants or the methods in other grants. That recommendation comes from the fact that it is the score on NIH grants for the approach that is most predictive of the overall impact score on the grant rather than scores from the other criterion areas. And in a kind of natural experiment from Canada, Whitman reported that when reviewers were asked to evaluate grants on the basis of the proposed research, so sort of the approach, there was no gender difference in the rate of awarding grants. But when reviewers were asked to evaluate the researcher, the scientist, again, where you might have this more lack of fit, women were disadvantaged. I think they were 7% less likely to be awarded. So I would suggest focusing on the approach. And finally, avoid description of childbirth or parenting to explain any employment gaps. And research that would support this recommendation actually comes from your own amazing Shelley Carell at Stanford, who has published very, very elegant experimental research and audit studies looking at how just a tiny signal of motherhood can lead to a whole host of negative evaluations in employment settings. Also, there are several papers coming out showing that physician mothers report discrimination. So refer to yourself by your last name, make sure your methods are really tight, and avoid any description of childbirth or parenting that could really trigger female gendered stereotypes. Okay, so bias is a habit that can be broken. This, in fact, this breaking the bias habit is really the only effective strategy that has been shown to be able to change behavior in response to these bias habits. And this approach is referred to as motivated self-regulation of bias in social psychology. It's referred to as intuitive override in judicial reasoning, and we refer to it as breaking the bias habit. And as you know, breaking any habit requires more than simply good intentions. It's a multi-step process. It requires awareness and motivation, self-efficacy, right? You have to feel confident that you can make a new behavior. There'll be some positive benefit if you do, and you have to deliberately practice the new behavior until it becomes habitual. So we had an opportunity with an NIH grant to develop a bias habit reducing workshop addressing all those stages of behavioral change on that last slide. And we conducted a cluster randomized controlled trial involving all 92 science, technology, engineering, mathematics, and medicine departments at UW-Madison, or units that function like departments. So every division in the Department of Medicine was treated as a department. Our 4 units in pharmacy that aren't official departments were treated as departments. And then we randomly allocated 46 of these departmental units to get this workshop and 46 to remain as controls. And the outcomes were online surveys that essentially assessed those stages of behavioral change given at baseline before the workshop, 3 days after the workshop, and then 3 months later. And using mixed effects linear models, comparing faculty allocated to the experimental group versus those in the control group, we found that faculty in the experimental group at 3 days or 3 months were significantly more likely to be aware of their own personal bias. They felt motivated and confident that they could engage in bias reducing activities, and they were doing so on a regular basis. Well, you might say, okay, Molly, these are statistically significant, but look at that y-axis. Those are pretty tiny changes on a Likert scale. Does it have any clinical significance, if you will? So we have another study that we run through WISELI. It's led by Dr. Jennifer Sheridan. And this is a postal survey that goes to all faculty at UW-Madison. And we timed it. So one of those surveys was deployed before any department got a workshop, and then after all the experimental departments got their workshop. And we pulled out the 92 STEM departments and looked at questions that got at department climate. And the findings suggest that faculty in the experimental group were experiencing a more inclusive department climate. They were significantly more likely than faculty in the control departments to say they felt they fit in their department, they felt respected for their research and scholarship by their colleagues, and they felt comfortable raising personal or family obligations, even if it conflicted with departmental activities, which we thought was a really important finding in the days of real concern about faculty burnout. So you might say, okay, well, this, maybe suggests that you had a little bit more sort of institutional impact by changing faculty behavior, but these are self-reported surveys. Do you have any really hard data? So we went back and looked at hiring outcomes in the experimental and control departments, 2 years before the study, 2 years after, looking at the percentage of faculty in different groups. And so the first set of bars on the left looked at the percentage of women among new faculty hires. In the experimental departments, there's essentially gender parity. Essentially 50% of new hires are women, 50% are men, with no change in the control department. Now, the focus of this intervention was reducing gender bias, because that was the focus of the RFA that was funding the study. But we also looked at percentage of new hires among non-white faculty, among historically underrepresented ethnic racial minority faculty. And we also saw a slight increase in the experimental department and actually a slight decrease in the control department. Now, if you use inferential statistics as a sample, these are not statistically significant, but we had the entire population of STEM departments at UW-Madison. So these are real findings. This is a real increase in our women faculty and in our faculty of color. We also found that departments in the experimental group had significantly higher retention of male faculty. All right, so the next step, obviously, is to see whether this approach works beyond just one institution and beyond just a focus on gender bias. And as Dr. Harmon mentioned, we're conducting the BRIM study, Bias Reduction in Internal Medicine. This is also a cluster randomized control study. We've adapted the workshop, trying to keep the structure as similar as possible, but obviously updating it and changing the content so it would be more relevant to faculty in a clinical department. The divisions within each department are randomized to get the workshop early, group 1, or later, group 2, so that the group 1 divisions remain waitlist controls for a certain amount of time. It's sort of a stepped wedge design with one step. And outcome measures are response to surveys. So these are the 19 participating departments. We have pretty good geographic distribution. We have very good distribution of public and private institutions. And the study is still going on, but after we had completed 12 group 1 workshops for 12 sites, group 1 workshops for 12 sites, the pandemic hit. And nobody was doing in-person workshops in the foreseeable future. So we had to convert the intervention to an online format. And we really didn't have the evidence to support that that was an effective intervention. So it made sense to look at the results of the first 12 sites. We will be looking at all the sites. But just to pull out some of the questions, comparing the first 12 sites with the in-person workshop. And in the interest of time, I only pulled out one question, but several others do also suggest an effect. So this question about intervening if I witness a student, resident, fellow, or colleague being treated in a biased way. And in terms of agreeing across a 7-point Likert scale that I engage in this action on a regular basis, you can see at baseline, there's no difference between faculty in the experimental or control group, group 1 and group 2, but at 3 months, faculty in the divisions that got the workshop are significantly more likely to agree that they engage in this action on a regular basis, and there's no change in the control faculty. Well, you might say, you know, how do we know this isn't just an example of social desirability? You know, maybe the people who got the workshop, you know, they know what's expected of them to answer. They like those people from Wisconsin who gave the workshop, you know, so they want to make them feel good with their answer. So to try to get around this, we pulled out the results for faculty who were allocated, were in a division that was allocated to get the workshop. They responded to the survey, but they did not come to the workshop. So to see whether there was sort of social diffusion of the impact of the workshop on non-attending faculty. And as you can see, this arrow points to those participants. Their slope looks much more like the faculty in their department who attended the workshop than they do the control group. So at least with these preliminary data, we are optimistic that this breaking the bias habit approach, once again, this motivated self-regulation of bias is going to be effective. So I want to leave you with 2 of the strategies we give the participants in our workshop, evidence-based strategies that you can all practice to help you break your own bias habit. And the first one is adopting a growth mindset. You, of course, are at the mecca of growth mindset because this growth mindset is based on 20 years of elegant experimental research by Carol Dweck at Stanford. And her lab has done research testing whether this growth mindset approach works to reduce the behavioral impact of these implicit biases, these cognitive habits. And it does, even with behavioral outcomes. So you should really recite daily as a mantra, something like, with hard work, I can overcome the influence of stereotype-based bias on my judgment and decision-making. You know, write something like that and stick it on your bathroom mirror, put it on your computer screen, have a growth mindset to overcoming the influence of implicit bias. The second strategy is called perceiving variability. And this is intentionally reminding yourself that every group is comprised of multiple subgroups. Because the more heterogeneous you view any group as being, the harder it is for you to apply some characteristic to that whole group, to generalize from a stereotype. So to practice perceiving variability, tune your ear. Listen for whenever you hear somebody say, members of some group are, whatever the group is, women are, men are, Asian people are, people from Southern California are, people from Wisconsin are, surgeons are, whatever. The next word is going to be a stereotype. So tune your ears. This provides a wonderful opportunity to practice perceiving variability. So just as an example, somebody recently said to me, women physicians want to work part-time. I immediately responded, Some women physicians want to work part-time, some want to work full-time, some want to work 24/7. I also took the opportunity to remind him that some male physicians would like to work part-time, but the stigma against it is preventing them from doing it. So anyway, growth mindset and perceiving variability. All right, so summary and conclusions. Just knowing stereotypes about groups of people creates cognitive bias habits. These bias habits make us all unwittingly complicit in the perpetuation of inequities in our society. But with hard work and intentional practice of bias reducing strategies, bias does appear to be a habit that can be broken. So thank you for your attention. I'm happy to try to answer any questions.
Dr. Carnes, thank you so much for that wonderful talk. So exciting to hear about this workshop and kind of the improvements you've seen with this 3-hour workshop across multiple sites. Curious, I'm going to kick us off with questions. Essentially, you had covered, particularly in your slide on efforts around the grant applications and steps that basically people who are at risk of kind of stereotypes, in that example with women, can do to kind of combat that. And curious, what should systems be doing differently so that, in that example, women can kind of show up as they are without that additional layer of thinking through strategies to diminish that?
What can systems do? Well, I think they can do some of the things. I mean, NIH now is, well, first they mandated, which always worries me a little bit because mandating things, requiring them can really backfire. Notice ours were all voluntary. But anyway, they are mandating, they're calling it implicit bias training for all people who are working for NIH. And that's a huge number of people. And their training actually includes many steps that would be kind of aimed at breaking bias habit. They have many of the steps we have in our workshop. You know, they create sort of source credibility by having Frances Collins and Hannah Valentine, little clips of them. Then they show some data. They, show the problem, how, implicit bias functions as a habit and cause problems. They then give very specific behavioral strategies that people can use, just like we do in our workshop. And they end with an implementation intention exercise, which is exactly what we do. So I think their training is quite good. Implementation intention exercise is these sort of if-then scenarios. So very specifically, if I'm in a situation where this happens, then I will do this. So I don't know exactly how they're studying that, but in terms of an evidence-based intervention, that's as good as you're going to get. I mean, because we really have, I think, the only controlled studies where participants are sort of the people who might be grant reviewers, faculty in academic STEM, showing that this kind of intervention works, and they're doing it. So I think, NIH, at least the biggest grant funder, is taking these kinds of biases very seriously.
That's wonderful to hear. Yes, and we are delighted, especially in hearing about this with Dr. Valentine back here at Stanford after her time at the NIH. I wanted to go to a question that has kind of been upvoted by our audience, originally from Talia. So it says, can you go, Dr. Carnes, can you go into more detail about how women tend to lead with the transformational style of leadership that you mentioned? Could it be because women tend to be more nurturing? And is transformational leadership, quote, the right path for women?
Well, transformational leadership is the right path for everyone, all leaders, because research from the military, industry, education shows that people who lead with a transformational leadership style are the most effective leaders, and particularly in academic medicine. You are a valuable leader if you're a transformational leader, because you are leading a group of very expensive individuals, physicians, scientists. So if you're a leader who can get those people to invest that discretionary effort in the organization, I mean, you are really, really a valuable leader. So there's many reasons I think women are more likely to be transformational leaders. They do not get advantage by the fact that they look like a leader. So that advantages some men who may not actually be good leaders. You know, they look like a leader, so they may get promoted on that, but when they get there, they might, and you know, we can all state, I think, personal examples of men who, if you just looked at their picture, they look like great leaders and they're terrible leaders. Women are going to be weeded out before they get there, right? So women are not advantaged by that sort of glass escalator that they look like a leader. So from the beginning, they sort of have to be more effective. Also, research shows there's no gender difference in the effectiveness of leaders. So for example, Alice Egley did a meta-analysis of 45 studies that looked at the effectiveness of leadership by gender, no difference. But the only time there was a difference where women were evaluated as less effective than men was when they led with what might be called sort of a male type leadership style. Basically, they only drew from the agented column. They were viewed as less effective. That didn't harm men, probably because they weren't seen as violating those gender norms. So, so women probably are not allowed to do that. Also, there's quite a bit of research showing that women are most effective when they do combine those agentic and communal traits. Actually, experimental work coming from Madeline Heilemann, where participants, for example, had to evaluate a male or female applicant for a vice president position. And they had all this agentic stuff about them. They, you know, they had high goals, they worked their people hard, yada, yada, yada. And then randomly assigned, well, it was either Andrew or Alice, and then randomly assigned, they either really cared about members of the organization or that sentence wasn't there. And just showing that communal activity completely eliminated assumptions that Alice was going to be hostile, difficult to work for, you know, aggressive, those kinds of things. So yeah, women are definitely advantaged if they combine agentic and communal behaviors as they enact leadership.
All right, thank you. And then hopefully we could have you answer, maybe stay 1 or 2 minutes over just to answer 2 more questions. Thank you, Dr. Carnes. The first was, Dr. Poon asked, does age affect bias? How would you suggest dealing kind of with bias within different age groups? It's a really interesting question.
Well, I think, you know, there are probably cohort effects for some things. If you look at the implicit association test, which has been criticized on whether it actually predicts behavior or not, but it definitely shows that we know stereotypes, right? Because it wouldn't work if we didn't. So if you know what I'm talking about, Brian Nosek and colleagues, Tony Greenwald developed this implicit association test where words or pictures are shown on your computer screen and you have to push keyboard keys to link them, and some are stereotype congruent and some are not. And the vast majority of us are much more quick to match stereotype congruent words or pictures than incongruent. And that's taken as a measure of your implicit bias. So if you look at scores on those, there's really no change with gender and no change with race by age. There does appear to be a lot less LGBTQ bias. Yay. There was also a recent paper that came out that showed that the Black Lives Matter movement may have decreased some of the pro-white bias on IATs, but I don't think it had a specific age effect.
Thank you. And then I'm going to go to Dr. Salas, who is live with us, one of your colleagues as well, for our last question, and then we'll end. Dr. Salas.
Hey, Carla, I just see Carla Pugh.
Yeah, Carla's making comments in the chat as well. Well, thank you so much, Dr. Carnes, for sharing all this information with us and for doing all the work that you've been doing really for decades to understand the barriers and challenges for women in medicine. You mentioned a few minutes ago unconscious bias trainings. And I have a question for you specifically about those. One of the things that I see, and I'm sure you do as well, is that when there is an issue that arises in an organization or even in our society, people are very quick to say, well, they need to do an unconscious bias training, or this organization needs to mandate unconscious bias training. We also see organizations listing, oh, we've mandated unconscious bias training, as though that's the solution to these problems. I wondered if you could talk just for a minute about, well, I don't know if you agree with me, but that I don't think unconscious bias trainings are the panacea. That's going to solve all of our problems with bias in our society and in our workplaces. So one, I guess, do you agree with that? And then if you do, could you comment on what qualities, you kind of alluded to them a little bit earlier, but what qualities make an effective unconscious bias training so that people can understand they're not all the same, and there are some qualities that we really need to make them effective. So it's not just check, we did unconscious bias training, but how did we do it?
Yeah. I mean, to me, it's like people say, oh, you're sick, you need a drug. Right. Like, what is implicit bias training? Because, I'm a physician scientist, and I like to take an evidence-based approach. And if you do that, there's so much research showing, depending on what that training includes, it could be totally counterproductive. So if it only includes increasing awareness, that is essentially comparable to the control group in a lot of Carol Dweck's work, establishing a fixed mindset. Right? If you tell people, if you live in this society and you're bombarded with these messages, you all have these implicit biases. That's essentially the control group in her work. And it makes it worse, right? Also work actually again from Stanford, Bernard Monin, you have all these great people there on moral licensing, right? So you could get him to come and speak at your grand rounds, or somebody from his lab. If you think you've taken implicit bias training, and you think you're not biased, you may actually be more likely to engage in bias in your decision making. Again, he's got elegant experimental studies to show this. So, and there's a lot of other studies besides Monin. There's Kaiser's group at Washington, other groups too, that basically all these studies, participants engage in some activity that lets them see themselves as non-sexist or non-racist or objective. And then after some intervening task, they're given some evaluative task, like they have to evaluate identically credentialed male or female applicants, or they have to evaluate a Black or white employee for a performance evaluation. And across all these studies, those people who see themselves as more objective give the most biased evaluation. So you could totally be making things worse by just increasing awareness or making people think they're unbiased because they took this training. Does that answer your question?
That's great. Thank you.
Thank you, Dr. Carnes. It's 9:05, and we thank you so much for your extra time. This has been wonderful, and now we have all these strategies. I'm loving to hear about the folks on campus around doing work with moral licensing in relation to these types of trainings and workshops and how to do them more effectively.
Yeah, or you should have Carol Dweck come and talk. Her stuff with growth mindset and reduction of bias is just beautiful, just elegant.
Right. Wonderful. And thank you so much, Dr. Carnes, for joining us and staying a little bit late. We have a number of questions. And so what a way to continue our series here this month.